Welcome to the second session, a session that will now focus on cellular and molecular markers of DRD and their relationship to retinal function and its perturbation during diabetes. We will have two talks in this session that will discuss the work performed to provide the community with a better assessment and understanding of the structure-function correlation using human ocular tissues. These talks will set the stage for a subsequent discussion relative to what we can and need to learn about the human pathophysiology of DRD at various stages of the disease and how it will inform the identification and validation of endpoints in the clinical settings. I now would like to welcome Dr. Chandra Balarathnathsingam, a clinical professor at the University of Western Australia Medical School, Centre for Ophthalmology and Visual Science, affiliated with the Lions Eye Institute. Dr. Balarathnathsingam has led some seminal studies to improve our understanding of the cellular impact of DRD both in the clinic and in the laboratory setting, giving him a great perspective on the topic of his talk today, the pathophysiology of DRD and its relation to visual function. Chandra?
Thanks, Patrice, for the invitation to present today at the Mary Tyler Moore meeting. Good morning, everyone from Australia. I'm going to give a very brief presentation just presenting our data on the use of human donor eyes to advance our understanding and knowledge of diabetic retinal diseases. These are my financial disclosures, none of which are relevant to this presentation. Speaking of diabetic retinal diseases, I'm sure that everyone in the audience understands the complexity of this disease, and that's largely because the retina itself is a very complex organ or tissue. With the exception of the brain, it's arguably the most complex tissue in the human body. The paradigm for understanding diabetic retinal diseases these days, it's generally accepted that we can divide the retina into three components. We can divide it into the vasculature, which comprises of endothelial cells, smooth muscle cells, pericytes. We have the glial cells, which are the major supporting cells in the retina. And then we have finally the neuronal populations, which include the ganglion cells, the bipolar cells, and the nuclear cells. And the interaction of these three cells or components is what we describe as the neurovascular unit. And they work cohesively in the process of diabetic retinal disease. I think it's really important to say that histology is invaluable for understanding diabetic disease mechanisms, but beyond that, it's not just histology that's important, it's human histology, because as we're all aware, we have these fantastic animal models for diabetic retinopathy, but a lot of those models don't have a macula. So it's very hard to extrapolate all of that information to human disease when most of the visual loss really occurs at the macula. So it's critical that we have human donor tissue for our understanding of conditions such as diabetic macular edema and ischemia. High-resolution clinical imaging, of course, has shown major advancements over the past 20 years, and this is the latest generation OCT released by Heidelberg Engineering, which really does allow us now to start looking at structural elements in the retina at very fine detail. You couple that with something like OCT angiography, which has been around, you have a very powerful mechanism for studying clinical disease both in cross-section and longitudinal fashion. However, it must be remembered that to understand diabetic retinopathy, we really do need to look down at the fine levels and the interactions between different cell components. And yet we can't achieve that using commercial clinical imaging devices that are available. We're still very much reliant on histology. In Australia, the Lions Eye Institute, our group has really optimized this technique of isolated ocular perfusion using human donor tissue for nearly 25 years. And this effectively involves cannulating the central retinal artery or the ciliary artery with glass micropipettes and perfusing each of the retinal circulations with varying antibodies based on what we'd like to study. And this has really been a really useful technique for us to delve down into the mechanisms that cause structural and functional changes within the retina in diabetes. And once we've perfused the tissue with antibiotics, we can now examine the sample with confocal scanning laser microscopy. And really now we can divide the tissue into each of the vascular plexuses. You can divide the tissue into the superficial plexus, the intermediate plexus, and also the deep plexus within the macula. And although this can be done to an extent using OCT angiography and clinical vascular imaging, it's certainly not the level of precision that one needs to understand the stratified way in which diabetic retinal disease influences the vasculature of the macula. Of course, once we have this, very high, highly detailed information and volume of the macula, we can start applying the latest and greatest softwares to study these structural details in 3 dimensions, which is key for our understanding of disease processes. I'm going to quickly provide an overview of where we see the human donor histology at this point in time can be invaluable for advancing our knowledge and the gaps in knowledge for retinopathy. I think the first instance is looking at early detection and biomarkers of early retinal injury. The second, of course, is exploring new therapeutic targets for conditions and complications we have no treatment for. And finally, of course, unraveling new frontiers and disease mechanisms. So if you were to speak about the early detection of diabetic retinopathy, as everyone in the audience would know, the clinical classification of this still goes back to the ETDRS publication published in 1991, which informed us that using color photography, the first sign of retinal injury is the formation of a microaneurysm. And although this is a very useful clinical tool, the histology provides compelling evidence, including research from our group, that microaneurysms, once they form, it already signifies a stage in the disease process where irreversible retinal injury has already taken place. So the state of the art for detecting and screening retinal diseases really is to detect these changes much earlier than when the microaneurysm forms. Using human donor tissue more recently, we've been focusing on the structure known as interpericyte tunneling nanotubules, IPTNTs. These are structures that have been reported in the human brain, and also some beautiful studies on rodent retinas as well, done by the Melbourne group. But we've really been focusing on that in human donor eyes, and they're far more abundant than one would expect. And these are specializations that connect one pericyte to the next, and it really provides a very fine mechanism of regulating and coordinating blood flow between vascular beds that may be separated by 50 or 100 microns. And the communication through these beds is in the form of calcium signaling and mitochondrial movement. We've recently submitted this data for publication where we've looked at changes in IPTNTs in patients that have preclinical retinopathy, so human eyes that don't even manifest a microaneurysm, yet they show diffuse and significant reduction in IPTNT. So if we can visualize these structures clinically, then that's a really useful way of detecting very early retinal injury. The next, of course, is looking at how can we treat retinal ischemia, which is so common in diabetes. It is a very significant cause of irreversible vision loss, and we still don't have a treatment for it. And we've really been leveraging this concept of endothelial dysfunction, which really affects every vascular system in a patient with diabetes. Now, with respect to the eyes, endothelial dysfunction is seen very early in diabetes. Again, in preclinical retinopathy, before we see microaneurysms, we're seeing signs of endothelial hypertrophy, which within capillaries and arterioles, which is leading to luminal narrowing, which is the precursor for vascular occlusion. If we look at specimens with more advanced retinopathy, not just preclinical retinopathy, we see profound proliferation of endothelial cells within arterioles and capillaries to cause complete occlusion of the vessels. Now, this is not a new concept. It certainly has been described many years ago by other investigators, but we're focusing on it to try and understand what triggers the endothelial cells to proliferate. It's very much an energy-dependent and coordinated, deliberate process. So if we can prevent that or reverse that, we may have a viable target for the management of retinal ischemia, or at least the prevention of it. Finally, the one thing we're looking at in great detail now is looking at glial cells in the retina. I think we would all agree that glia are so abundant in retinal tissue, but there's no way of clinically visualizing it, and there's certainly no treatments to modulate the behavior of retinal glia, which I think really would be the game changer in the management of diabetic retinal disease. We've recently started looking at retinal microaneurysms in diabetic patients to look at how the glial cells surrounding it change. And we're finding these very strong associations between sites where microaneurysms form and also where the glial cells remodel. So we don't know what the cause-effect relations are just yet, but what we have found is that if you have significant glial remodeling around microaneurysms, then that is a very strong protector of vascular leakage. So you can see two microaneurysms in this human specimen. The glial proliferation is labeled green. Aneurysm 1, which has a lot of glial cells surrounding it, has no leakage, whereas the adjacent aneurysm with barely any GFAP staining has got diffuse leakage. So I'm just going to end there. This is a very short overview of how powerful human donor histology is and how important it is to our understanding of diabetic retinal diseases. And thank you very much once again, Patrice, for the invitation, and I'll hand this talk back to you.
Thank you so much, Dr. Barnett-Nissingham. Next, I will be presenting on the topic of changes in the retinal neurovascular unit at the cellular level in DRD. I am Dr. Patrice Fort, Associate Professor of Ophthalmology and Visual Sciences at the University of Michigan. I also serve as the Director of the Mary Tyler Moore Vision Ocular Biorepository and Resource Center. As you know, diabetic retinopathy has been described as a microvascular complication with emphasis on vascular perturbation, which is visible, without understanding very clearly the impact on the neuroretina, the invisible part. However, there is much more than what is visible that we need to better know. In addition to the vascular permeability and vascular dysfunction, there is clear evidence now on neuroinflammation associated with glial cell activation, as well as neuronal damage and even cell loss. All in all, it affects the entire neurovascular unit. This is what led us to coin the term diabetic retinal disease rather than diabetic retinopathy, and lead us to really go after what are the changes that are affecting the whole neurovascular unit, and how is diabetes affecting the neuroretina. We really need to get a better and more specific characterization on all the way to the local aspects of DRD. Our strategy has been twofold. First, to perform multiomics analysis of retinal regions and fluid, including vitreous and aqueous humor, to get a global understanding and assessment of what diabetes is doing to the neurovascular unit. And as the technology has been improving, we are now trying to get into more spatial analysis of those changes and assess those in conjunction with phenotyping. On the first level, relative to the general molecular analysis of DRD molecular mechanisms, we have been using human donor tissues and dissecting the different retinal regions, isolating the fovea from the macula, the mid-periphery and the far periphery, in conjunction with the aqueous humor and the vitreous humor, as well as blood samples. We are looking at studying this in conjunction with the clinical phenotyping of those donors with and without diabetes and with and without diabetic retinopathy or diabetic retinal diseases, and perform multiomics analysis, assessing the impact of diabetes on the transcriptome, proteome, lipidomes, and now pushing farther into single-cell analysis. By doing so, we get an overview of the impact of diabetes at a different level of the regulation of retinal function through molecular analysis. Here, showing some of the results that we have had looking specifically at proteomic changes, differentiating them between the macula, the peripheral retina, and the vitreous, that highlights how each one of those regions is affected somewhat differently and at different stages of the disease, going from diabetics without DR to diabetics with mild DR and diabetics with severe DR as a factor of the progression of the disease. And on the left-hand side is an overview of the changes of the proteome, whereas on the right-hand side is the type of pathway analysis that we're able to provide and to obtain with those samples. That gives us a more detailed view of how each of those different tissues are affected by the disease. From there, as I mentioned, we are now pushing towards more spatial analysis in conjunction with phenotyping. What that requires is first a detailed phenotyping and grading of the tissues that are obtained and the donors from which they come. For this, we are performing fundus photographs and parallel to the clinic with joint assessment of the retina through OCT analysis. Here showing you the correlation between the fundus on the left-hand side and the corresponding region assessed by OCT. And we do the same thing for all donors with and without diabetes and DRD. And here is just an example of the type of imaging that we're able to do on those donor tissues, where you can see in this context of an hemorrhage, the OCT imaging corresponding to the same region seen by fundus on the left, and the OCT on the top right. And corresponding below is the OCM, a method that allows us to get higher magnification and higher resolution of those images. We can do that for all types of DRD features to better understand how the neuroretina is affected in that region of those features. As I mentioned, this is an hemorrhage, but we can do that for all sorts of presentations, all the way to laser scar formation and looking at the neurovascular unit around those different features. From there, what we want to do is couple those images with cellular analysis of the neurovascular unit. Here you see a merged image of a couple of regions from the retina from some of our donors from a non-diabetic normal retina. And this corresponds to co-staining using collagen 4 as a marker of the matrix of the vasculature, is in conjunction with a UEA staining marking endothelial cells and cells forming the vessels, as it's been used by some of our collaborators in other groups, including Chandra's group as well as Marcus Frutiger's group, to demonstrate that those can be used to assess some aspects of loss of perfusion in the retina. Here is an example of a region that shows normal perfusion, and we can continue assessment in other contexts. Here, some partial loss of perfusion represented here in the center of the slide, all the way to regions that are correlated with the fundus photograph that I mentioned before, and showing, again, loss of perfusion in conjunction with slight hemorrhage, where you can see blood cells that have invaded the neuroparenchyma. And finally, all the way to regions that are completely that have completely lost perfusion, and that can be used to assess how those regions are showing changes relative to other regions of normal perfusion, including in the same donors. The goal is to use those phenotyping analysis and imaging with cellular analysis of the neurovascular unit using a combination of single nuclei RNA-seq and spatial analysis of specific regions and specific DRD features to identify how those features are affecting, or how the retina around those features is affected. And here is an example on the left-hand side of a first round of analysis that's been done at the level of the single nuclear RNA-seq, showing the identification of all retinal cells. And then on the right-hand side is an example of MALDI imaging, looking at the different layers of the retina relative to lipid composition. And the goal is to get after the changes that are affecting the retina in the different stages of the disease compared to the normal retina. As always, this is a group effort, and I want to acknowledge all the people involved in this project. On the left-hand side is the leadership team of the Maritime World Vision Initiative. In the middle, the MTM Vision Biorepository and Resource Center group with Kelly, Corey, and Carmen that are instrumental in driving this whole project. On the right-hand side, my group at the University of Michigan with Yang, Linda, and Rashana, who have been instrumental in getting this whole project started. And then our collaborators, both at the University of Michigan, as well as in other academic institutions that are helping with different aspects of this project. I now invite you to the open discussion. In this live session, I'll remind you that we will be looking for an interactive session answering questions from the audience. So please feel free to send in your questions and we'll address them.